for today, we're going to do a really brief, because there might be some folks who couldn't come last time. So I'm going to do a super quick review of just some of the pieces we covered for part one. For some of us, it might just be helpful in waking up our hippocampus. Then we're going to jump into part two, and we're going to start talking about treatment for trauma in the context of psychosis. Again, I just want to kind of orient everybody to expectations based upon your program. So if you're in an established program, you're already doing this work, you need to be thinking about how you're currently assessing and treating trauma and where you may be thinking about integrating things. If your program's newer, how might you integrate some of the things we're talking about into the work you're going to do? And then if you're part of our collaborative program, to just think about how you all do this in the broader community. All right, so here's our review. And again, Kristen's going to be able to take us through more of this case. So in my piece of assessment, when we talked about the background, right? We talked in that about having a trauma-informed program and setting using SAMHSA's guidelines for a trauma-informed program. And many of you commented on this in your feedback, this idea of having a healthy organizational climate. If you're going to be talking about tough stuff with your clients, you need to have a clinic that is supportive and responsive to that. So that was an important piece of feedback we saw as well. We recommended particular screeners as part of our intake evaluation. So for adults, we use the life events checklist with the post-traumatic stress disorder checklist for DSM-5, PCL-5. And for youth, we use the CATS, which also has a life events checklist. We reminded you all that you use these screeners in combination with the measures that you also do, right? Because we're thinking about differential diagnosis. We're trying to understand how these experiences that folks are talking about that may be related to trauma could also be related to other experiences. And we also talked about the importance of considering the role of community, culture, and language. We can't evaluate folks in like a box without considering all of these other important factors that make them who they are. Okay, I also want to remind folks that this is in the in Beehive. So if you are part of the Learning Healthcare Network, one of our screeners is the ACEs. And remember, we talked about how the ACEs is just a measure of adverse childhood experiences. It isn't a trauma measure. So one of the things we did is we set it up so that a score of 4 or more, that should trigger you all to administer the CATS and the PCL, which are in the trauma bundle. So making sure that you push those to your clients so that you can get that trauma data. You have to manually assign it. Beehive doesn't do it for you yet. And then you could administer them standard to everybody. So assign that trauma bundle to all clients so it's automatically pushed. That's what we do in my clinic. We just automatically push it. So these are some choices, that the leadership can make in how they want to handle this. I also, in that Dropbox link, for those of you who are using Beehive, I put in there a bunch of other items that are asked in the client bundle, in the support person bundle, that could signal possible stressors or traumas. And so I just encourage you to go look through that. I want to thank Dr. Arashevsky for helping me put that together. It's just another place where you might see like, could there be other significant stressors? All right, now I'm going to turn it over to Dr. LaCrosse, and she is going to remind us about Roger.
Thank you. I'm off mute now. So yes, last month we briefly touched upon Roger's story, but I'm going to revisit it a little bit briefly, and then we'll talk more about what came from his assessment, his intake appointment, and the follow-up assessment. So Roger is a 17-year-old biracial male who identifies as African American. He's been living with his maternal grandmother for the past 2 months, and she was the one who had accompanied him to his intake appointment and provided some additional collateral information. He was referred by his primary care physician after complaining about sleep problems. And then he disclosed to his doctor that he was actually having thoughts that his mother, as well as his younger brothers, were actually reptilian aliens. And so this led him to go 2 days without any sleep because he had concerns that he'd be taken over by these aliens. And so this eventually led him to feel so uncomfortable in his own home that he eventually left to live with his grandmother. So in terms of the intake assessment, a clinical interview was conducted. He didn't report any significant medical history, prior psychiatric hospitalizations or treatment. He did endorse some experimental drug use within the past month, including cannabis and Adderall. And then he also endorsed some social drinking since the age of 14, typically just 2 beers, but on occasion, 5 to 10 times since the age of 14, he endorsed binge drinking. And then he was given certain modules of the SCID and was diagnosed with schizophrenia with the onset of early June in 2021. And the symptoms that he endorsed were the delusions that I previously mentioned in terms of his family members being reptilian aliens. And also he endorsed mind reading delusions that other people can read his mind. He also endorsed voices, and which he expressed, he interpreted these voices to be aliens communicating with him. He was also given the CATS trauma screener because he's a youth. He's only 17 years old. And his grandmother was also given the collateral screener for the CATS. So in terms of, okay, so this is a little bit different than the last report or the last slides that we were using. But in terms of resolving discrepancies, there were certain items that he identified that his grandmother did not identify. So he identified experiencing serious natural disaster, a serious accident or injury, being robbed, being slapped or punched or beaten up by somebody outside of the family, seeing somebody in the community getting slapped or punched or beaten up. And then his grandmother, but not himself, endorsed that he had somebody older than himself touching his private parts when they shouldn't. And so for Roger, in terms of what he identified, was actually an item that both he and his grandmother identified, which was item 6, seeing a family member getting punched, slapped, or beaten up. His grandmother, on the other hand, identified item 8, which is somebody older touching his private parts when they shouldn't, as the most, what she believed to be the most distressing event. And this was, something that she identified that he experienced in his youth when he was a toddler, but he had no recollection of it, and so he did not endorse that. And so that came out in further interviewing that was done. Okay, so these are the explanations for the discrepancies that came up in the two, in Roger and his grandmother's CATS scores, or his endorsement of traumatic experiences. So the reason that they had different answers to some of these items, for one, Roger had only been living with his grandmother for 2 months. And so she was unaware of some of these experiences that he had earlier in his life. And then, as I mentioned, item number 8, which she endorsed, and he couldn't recollect any of that. So he didn't endorse that. And so he maintained that the most distressing event was item number 6, witnessing that his mother was physically assaulted by her boyfriend when he was 14. So, does Roger have PTSD? It's unclear at this time. More assessment is needed because, yes, he and his grandmother endorsed, quite a few traumatic events that he had experienced. and also quite a few symptoms that he experienced in the past 2 weeks that met the clinically significant range. However, it's important to really review the symptoms on the cats that were endorsed and determine if it's best explained by psychosis or if it's best explained by the trauma. So when kind of teasing this apart, you want to be thinking about the onset of symptoms. Did these symptoms present before or after the traumatic event occurred? Or did they present before or after the psychosis first started? Also, you want to be considering the context of the symptoms. Do these symptoms emerge only in the context of psychotic symptoms? So when they're experiencing delusional thoughts or hallucinations, or are they emerging alongside traumatic reminders of the traumatic experience? So in addition to that, teasing apart those symptoms, you also want to think about completing the trauma module of the SCID and seeing if an accurate diagnosis of PTSD is appropriate. So in terms of teasing apart trauma symptoms from psychotic symptoms, you'll see that some symptoms on the cats are very specific to the traumatic event. So, for example, experiencing nightmares related to the traumatic event, or having intrusive memories or recollections of the traumatic event. And however, other symptoms on the cats that somebody can endorse are more general and could actually be better explained by potentially some other issue that the person is experiencing. So in this case of Roger, after additional time with him and interviewing with him, it seemed that these 4 symptoms, feeling overly alert or on guard, feeling jumpy, having problems paying attention or problems with sleep, these seem to be emerging more recently than his traumatic experience that he endorsed, which was when he was 14, witnessing his mother being assaulted. They emerged after the onset of psychosis and seem to emerge more in that kind of psychotic situation in which he's having delusional thinking or experiencing voices. So being able to tease apart that these symptoms were specific to that kind of situation and context and onset versus otherwise was helpful to tease that apart. And so then the SCID trauma module was administered at some point in his treatment, and it confirmed that he did have a comorbid diagnosis of PTSD. And so these symptoms, the nightmares, avoidance of memories of the event, inability to remember significant parts of the event, having exaggerated beliefs that no one can be trusted, I'm never safe, having really inappropriate self-blame for the event, irritability, anger, recklessness, self-destructive behavior such as reckless driving and binge drinking. All of these he endorsed, and these were specific to the trauma, and therefore he met criteria for PTSD after some follow-up assessment.
Thank you, Kristen, for exemplifying how screening needs to be followed up by additional assessment. Because if we remember back to Roger and Grandma's scores, and I apologize that slide wasn't here, they both, the symptom score was very high and above the cutoff. So if you just take that and you say, okay, I've looked at these discrepancies and it looks like Roger's rating of, witnessing his mom be assaulted and he has the symptom severity level, he's got PTSD, then you miss the fact, as you've so nicely pointed out, that you need to go back and make sure the symptoms that they're rating are related to that specific event and not general symptoms. For me, trouble paying attention. Classically, lots of people report that, and cognitive symptoms are common in individuals with psychosis even prior to the onset of the psychotic symptoms. So you really do want to get in there and make sure that these are things that have happened subsequent to the trauma and are related to the trauma and don't just represent other symptoms that folks are having. So thank you for that really excellent example. So what I'm going to talk about in this next section is using assessment results to guide our treatment approach. How are we going to use the information we've gathered to make decisions? How are we going to integrate this into our treatment of psychosis? And then how are we going to keep an eye on this over time? So I'm going to talk about monitoring symptoms with the cats and the PCO. So first of all, let's just start with the evidence base. What does the research tell us, right? There are, as we know as clinicians, empirically supported treatment for PTSD. I mean, PTSD is probably one of the areas where we have done the most research and have some of the best evidence for things that work. And we know that we can use these things to reduce the cognitive, behavioral, emotional things that maintain symptoms. So cognitive and behavioral avoidance tends to be what maintains symptoms. So these are things like CBT, prolonged exposure, EMDR, and cognitive processing. So we know that these things work for individuals with PTSD. These all include exposure, and that exposure is either imaginal or in real life. Let's go and let's do these things that are scary. We have a growing evidence base for other therapeutic interventions like interpersonal therapy. But right now, we know these first-line treatments work, okay? So what does the research literature tell us about treating trauma in established psychosis? So these are folks who've been ill for a while and tend to be more stable. So think of folks who are in their 40s and 50s, not our folks who are in their teens and 20s. All right. So when we look, there's a number of small studies that support using these similar evidence-based practices with exposure in psychosis. So Fro and colleagues showed decreased PTSD symptoms for CBT plus exposure compared to treatment as usual. So just general outpatient treatment. Vandenberg and Mandergag showed reduced symptoms of PTSD, psychosis, depression, and anxiety doing EMDR plus treatment as usual rather than treatment as usual alone. And then DeBont should reduce PTSD severity with EMDR and prolonged exposure, okay? So yay, we've got some evidence that these treatments work in folks with established illness. So there's only one RCT of exposure-based treatments. And what they did here is so both PE and EMDR reduced PTSD symptoms when compared to a waitlist control. But it was prolonged exposure, not EMDR, resulting in full remission of symptoms. So keeping in mind, when we look at studies of CBT or other things without exposure, that's where the findings get more mixed. So Kim Muser, and in his work, showed that CBT and treatment as usual decreased PTSD and other symptoms compared to treatment as usual alone. Steele did not find reduced trauma or other symptoms for CBT plus treatment as usual. And both of them agreed at the end in their discussions that exposure might be the key to effectiveness. So I just want to remind everybody, even in EMDR, right? You're moving the thing, but you're talking through, you're exposing people to the experiences they've had. It's still exposure. That's the secret sauce in the majority of anxiety treatments in general, but most importantly for PTSD. Okay, let's see. So if we have data and we know that these treatments work, why aren't we all already doing them? why aren't all of us doing these things? So we were wondering this. We were like, why isn't this the case? So one of our former interns, Casey Cragen, she and I did a large study where we provided preliminary guidelines for the treatment of trauma in the context of early psychosis within 5 years, and for youth at clinical high risk, which many of us serve as well. And so what we ended up doing is surveying all of the experts we could find. We got responses from 118 people representing 121 EP clinics across 28 states. And all of them told us the barriers and concerns that they have to treating trauma. So, and so here we just had a discussion. How do we separate trauma from psychotic experiences? People felt uncomfortable doing that. I tried to illustrate how trauma and psychosis can interact with each other and even exacerbate each other. And Kristen sort of highlighted that too. Like, are you having this period of intense physical symptoms right now, and psychotic symptoms because of a trauma trigger? Are you just getting dysregulated? And then everyone very clearly said, we don't get training, we certainly don't get supervision, and nobody pays us to do that. And so how could you expect us to implement trauma treatment when we're already treating such difficult situations? So our team felt that this was a huge problem in our field, that we were ignoring trauma when we know upwards of half of our folks have had it. And again, for folks who were here last time, you remember that upwards of 80% of individuals at clinical high risk will have reported having a traumatic experience. So this is so common. We are not doing a service to our clients. So what we did is we collaborated with some folks at the UC Davis Care Center, and we developed a training program, and that is where Kristen was trained, to specifically develop a way of treating trauma in individuals with early psychosis and youth at risk. So we focused on individuals ages 12 to 30 who are within 2 years of psychosis onset or at clinical high risk. And we really took this evidence-based, body of literature and brought it all together. And for us, we focused on trauma-focused CBT. We felt like it gave us a nice structure where we could work. And so I want to be clear to everybody, that's going to be the frame I'm holding today. Although there's lots of different places for prolonged exposure, cognitive processing, and a good dose of DBT. Folks with a trauma history often need a good dose of DBT skills. So if you're thinking about, okay, where am I going to go after this training? TF-CBT training and DBT training. Those are the two little nice skill sets you can put into your tool belt to make use of this work. So here's how we're going to use our assessment to guide our decision making. Okay, so the client comes in and they present to the clinic. We do our SIPs, our SCID, our screening tools, and we kind of decide where are they falling on the severity continuum of psychosis symptoms and trauma symptoms. Okay, so down here at this side, we have psychosis or APS symptoms are prominent, no trauma. We are just going to move forward right into a psychosis-focused treatment approach. Down here, when we have both psychosis or attenuated symptoms and trauma, and they're equally present and very distressing, we're going to make some different decisions about how we're going to proceed. So let's come back down here to this lower end. So let's say now we have someone who has psychotic or APS symptoms, and maybe they've reported a past trauma, but that's not what they're distressed about. What they're distressed about right now is this prominent psychotic-like presentation. So let's just go through and do that PTSD interview to make sure, and then we're probably going to move forward with more CBTP with a sprinkle of psychoed about trauma and safety skills. So individuals who have had a trauma history are more likely to be re-victimized. So that's another reason why TF-CBT is a nice protocol, because it gives you a safety, like a little safety session that you can do with folks about safety skills. And so for somebody like that who has a trauma history, we just want to make sure they have skills to stay safe. So now let's think about somebody's coming in, they have prominent and severe psychosis, or their APS symptoms are pretty notable, and they have trauma present. So we know that it's floating there in the background and we need to pay attention to it. But this main presentation is the instability of psychosis. Maybe we're like trying to keep them out of the hospital, or maybe we're worried that they're going to develop full-blown psychosis. So we're going to focus on stabilizing that. Let's try to get those symptoms under control, and then come back. And once they're a little bit more stable, do that SCID PTSD section. We gave it 4 weeks, it might take longer. The idea here is don't lose sight of the trauma, because it could be driving the train. So just keeping that going. And then when you come to here, you're going to do our trauma integrated CBT approach. You might focus first on on psychosis and then on trauma. Okay. Now, you may also have individuals where there's a recent traumatic event, or those trauma symptoms are prominent, or maybe they have complex PTSD, and maybe their psychosis is there, but it's stable. Maybe they responded to medications, they're doing okay. Do that SCID PTSD module, and then move in to treatment with a primary focus on trauma, keeping in mind the psychosis in the background because you want to monitor it. Okay. And then finally, we get to this other side. You got both trauma and psychosis. They're equally present and distressing. Hopefully the psychosis can be stable. You're going to move through that full assessment and then focus on both. Okay? So this is just an initial guide. Like, what am I looking at? Where am I going to go first? Okay. So the next part of this, now you're all sitting here being like, okay, great. What do I actually do? So here's, an example of a coordinated specialty care model. You got your teams, you could brought this person in, you have your assessment done, you've kind of staged your conceptualization about where you want to start first, okay? So your lead clinician, that's usually who takes lead on this, is going to begin to think about their initial case conceptualization. How much of this might be related to trauma? How much of this is psychosis? What are my first treatment targets? We're going to always think about case management, making sure they have what they need so they can be present in treatment, and then safety planning. So always making sure we have a sense of risk behaviors and safety planning in place before we move forward. Okay. Then we're going to provide our general psychoed about psychosis, making sure the family is engaged and has support. If you're going to link them to groups, and having a sense of how we're going to track their symptoms. How are we going to know if they're getting worse or getting better? So this cycle might go on for a little while. As the clinician gets to know the client, gets to know the family, we get those case management needs taken care of, hopefully integrate primary supports. Maybe you're working on meds, you're engaging them in groups with your peers, supported ed. You're going to work this loop a little while. Okay, until you feel like a person may be more stable. We want to have some stability. Okay, then we're going to start to integrate other pieces of psychoeducation. We're going to talk about other things that are relevant, just like substance use may be relevant, right? If trauma is relevant, we're going to talk about it too. And so again, this is where TFCBT has some really nice handouts on different kinds of trauma, how often they happen. Very simple stuff that a lot of clients like. Understanding how trauma affects the body. Most people don't know this. People don't talk about psychosis. They don't talk about trauma. They don't have a good understanding of what it means. This is another piece. Definitions, common reactions. I will see kids get dysregulated. And to me, it's a very clear response to some sort of trigger in their environment. Their parents have yelled at them. It reminds them of whatever it was in the past. And you see this kid get very dysregulated. And the parents will be like, oh, they're having a psychosis flare, or they're being oppositional. And it's like, oh, everybody, we just need to know what's happening in this moment for this youth. And once we have that shared understanding, we can then move towards doing more appropriate reactions and interventions. So psychoed. Then we're going to move to skill building. So we're really going to be focusing on understanding how they're coping now. What are they doing to manage these thoughts, feelings, and behaviors that are not just coming from the trauma, but also coming from their psychosis? Same thing, okay? And working on, and so TFCBT kind of divides this in a couple of bins. So they think of affective coping and cognitive coping and behavioral coping. And so you want to make sure that you've engaged these different coping skills and, allow them to pick where they want to start, what seems most natural to them. When they're feeling bad, what do they tend to do anyway to feel better? The saddest thing is when they're like, I don't know, nothing. You're like, wow, okay, we really need to build in some coping skills for you. So start to build that up. And you can weave this in with psychoed, different pieces. So affective, recognition and regulation, cognitive coping, and relaxation. So these are kind of the key areas we're going to be thinking of. So lots of folks always want to start with, the behavioral sort of, let's do progressive muscle relaxation. Let's do deep breathing. Let's meditate. That works well for some people, and for some people it doesn't. And this is where also your DBT skills can be helpful. So like tip skills, understanding that for some people, they really have to like push their body to some sort of activated edge before they're able to kind of calm down. For me, if you ask me to sit and breathe deeply, I can do that for about 10 seconds. If you ask me to run 2 miles to calm down, I'm with you. That's how my body's built. So really trying to understand for folks, like how do they respond better, and what skills do you want to support? The things that might work for you might not work for them. So this is a very complicated thing to kind of think through. The second point I want to make here is you are not allowed to take away ineffective coping until you have given them effective coping. So you may be like, I don't understand. They will continue to self-harm until they have something else they can do. They will continue to smoke weed, drink alcohol, whatever it is, until they have something else. So you really have to think about substance use, self-harm behaviors, even suicidal ideation and other behaviors related to, taking one's life. Those are things that folks will step up to because they don't have anything else in their toolkit to use. So again, finding things that work for them will then allow you to remove the less helpful coping skills. But a lot of folks want to be like, you can't smoke weed anymore. Well, okay, but they're going to do something else that isn't going to be great because they don't have any other tools in their toolkit. So really sort of thinking about how do you ramp up the coping skills and then sort of, moving down on the less helpful coping. Okay. So these are kind of core skills. Then enhancing supports. So for any of you who have been to my suicide risk assessment and intervention talks, lack of natural supports, social isolation are huge risk factors for suicide and self-harm. So we need to find ways to enhance natural supports. And I think for many of our folks who have a trauma history, you're going to see a lot more non-suicidal self-injurious behavior, suicide ideation and behavior, and substance use. So you really want to be able to enhance the natural supports who are going to guide the person towards more effective coping and not encourage ineffective coping, right? Or belittle them or, invalidate the concerns, the feelings that they're having. So that's where really engaging with folks, the family, partners, best friends, whomever is in the person's life, to come into treatment, understand what are the coping skills that help, what are the things that don't, to know that safety plan and how to help the person access and work through the coping skills that are there. That is what helps someone stay out of the hospital, the emergency room, more so than us always being the ones who are doing that coaching. So here, enhancing supports, I think one of the other really important pieces here is, can these supports practice the coping skills when the person isn't distressed? Can they just help make it natural that this is what you do every morning, every day, every night, what have you? These are the things that I do to keep myself well. And we've incorporated a lot of this in our clinics into a wellness plan. So you might have a safety plan, but also you can have a wellness plan. What are the things I do to stay well? What are the things I avoid to stay well? So here we have our safety planning, that relapse management. So that's where that symptom tracking in that first circle. What are the things you are keeping an eye on? What are those early signs that someone's not doing well? We had a client come in last week, and one of my clinicians was telling me about this today. And he was like, I'm feeling kind of anxious and my thoughts are starting to go fast. We were like, right there, warning signs, because we knew this client. And otherwise, he looked great. Like, he looked happy, doing okay, getting more involved. But we knew that those were his warning signs. And that night, he ended up really having a big flare of symptoms. So knowing those things, even the most subtle things, and sometimes clients don't know. So you have to engage, again, those natural supports to be able to say, like, you're talking about anxiety and I'm having a hard time getting a word in edgewise. I'm starting to get a little worried, right? That's where folks can get some helpful feedback. Again, here is the place where we tend to think about abuse prevention and healthy relationships. Making sure folks have space to talk about the impact of those traumatizing experiences on their sense of self, on their view of the world, and then supporting them in thinking about how they build and maintain healthy relationships. Sometimes in this enhancing supports, you'll be like, they don't have any friends. They've burned through them all. Some of their family is left barely, right? How do you work with those families to pull them back in? How do you identify new people? Because sometimes they'll be great at making friends, but can't keep friends. So just really trying to understand how their trauma and or psychosis or substance use may be contributing to difficulty in social relationships and seeing that as a treatment target. And then talking very openly about risk for future victimization. Okay, so here we've got somebody, they know what's going on, they got some skills, they have some supports, we know how to keep them safe. All right. Now, when we have about 1 month of stability, meaning we haven't had any hospitalizations or urgent things seem all to be going in the right direction, we move to formal exposure. Now, I want to note that we've been talking about trauma this whole time. And that's exposure, right? Just doing psychoed is exposure. We have not at any point in here asked the person to tell their story. And that's a really important piece that I'll come back to at the end, is not allowing premature disclosure. So we've got somebody, and they've been stable for about a month. Now we're going to work on exposure, and we're going to do imaginal or in vivo exposure, and we're going to complete a narrative. And we have done this with adult clients. People are like, but TFCBT's for kids. Well, it's just actually a really nice structured protocol. And it works really well with adults too. You don't have to. For adults, we will give them the choice of whether they want to share their narrative with someone or just with the therapist. So that's one of the differences that we have. But we do the same sort of pieces of laying out what are the experiences that they have had. And then we go through and we make sure that we've identified the feelings and the thoughts that come up, through that story. You work through it a couple of times. And then at the end, you do a making meaning chapter. What does all of this mean for me as a person, and how am I going to move forward? For folks who have complex trauma, we take a hierarchy approach where we might start with the lesser traumas and work up to the more severe traumas, and all the time practicing those relaxation skills and coping skills that we need to keep them stable as they're going through. All right, so now I get to give a case example. This was a case that we had. Jose was a 17-year-old Hispanic male. He came to the clinic with his parents. His parents were both monolingual Spanish speaking. And he had a hospitalization for his first manic episode with psychotic features. This was in some ways an easy case, And, he stabilized quickly. He responded to meds, very engaged in treatment, family incredibly supportive. They were there. Everything seemed to be going swimmingly as far as these cases happen to go. And then he witnessed a shooting at his school. We realized that this was really important to him. And this came out as happening right before his first episode. And we realized, we were like, wait a second, everything's going so well, but yet we haven't touched this big event. And then we realized, perhaps this is why he's refusing to go to school or not go outside his house. So we really started to see the impact, because you could just assume, right? If you didn't think about that traumatic event, sometimes our folks who are having psychotic symptoms have trouble getting back to school and getting out of the house. That really wasn't what was driving that behavior. So in treatment, we worked on identifying the symptoms of mania and psychosis and trauma. We identified the reactions he had to that trauma and the triggers that he was experiencing. And then we talked about avoidance. Avoidance is one of the most challenging things we deal with as clinicians. It's a safety behavior. If we don't talk about it, look at it, whatever, it's not there. But really, we know it maintains the symptoms. So really talking about how avoiding school and not going outside his house was maintaining a lot of his distress. So we worked on relaxation. For him, that was really, really helpful. Deep breathing and progressive muscle relaxation were like his keys. We saw lots of avoidance for him and his parents. They were very much in support of him not going to school and not leaving the house. It was scary for them too. And so we worked with him and them on using SUDS ratings, subjective units of distress, to capture his distress. And for him, he called it anxiety. So we said, how anxious are you feeling on a scale of 0 to 10? And we would do that as we were doing psychoed, as we were doing coping skills. We brought the parents in because they were so afraid of him becoming psychotic again. They were having such a difficult time engaging him around the trauma. They just didn't want to make him sick. And so seeing that he could move his distress up and down was very comforting to them. We also talked about cognitive coping. As we were working on these things, we started to get little bits of his thoughts. What was he thinking about that kept him home? What was he thinking about that kept him out of school? And how do we talk with that? We, again, worked with the parents. We did a lot of psychoed with them. He taught them about his coping skills. And then again, we talked about the role of avoidance. We did some safety planning. We talked about relapse management. That was everybody's biggest concern. And we discussed community safety. We talked about his parents' very realistic concerns of the community that they lived in. And, how could they, what could he do to be more safe in the neighborhood? He was stable for about a month and we began exposure. So again, I mentioned we started those SUDS ratings during psychoeducation. And then we did some imaginal work about returning to school. And we were familiar with what the school looked like. This was a community college that he had been going to. And so we talked about what the parking lot looked like. We talked about what it meant to walk up the stairs and where the classes were, things like that. And then we started doing in vivo campus visits. The first time he went, he couldn't get out of the car. So we sat in the car. And that was a very intense 30 minutes. And his parents had to engage in coping skills because they were so worried about what would happen for him. So I think the most important thing for this is to really think about that hierarchy and, not jump in. You want to start small because otherwise people will avoid or they will get really distressed and angry at you. And that's just a sign you went too far, too fast. So start small. And that's where the imaginal piece is really, really helpful. Okay, managing challenges in treatment. Cognitive impairment. So this cognitive impairment could be secondary to psychosis, or you could have someone whose IQ is a bit lower. Keeping it very simple. Trying to use skills, coping skills that are very simple. Focusing on one small part of psychoeducation. Having them teach it back to you. Having them teach it to their loved ones. to make sure they're really understanding it. Being very concrete and using visual aids. These just go slow. Like you may feel like you are taking an eternity, but it's really about making sure what you're saying is sticking. And sometimes when folks are really, ill at the beginning and they're having a hard time even being present in the session, just doing some of this work with their support system can be huge and helping, their family, their loved ones understand what's going on and be more appropriately responsive than they might have been in the past, which then helps bring down the stress in the home and supports recovery. So, if you can't do it with the individual, do it with their loved ones. Do tiny bits of it. If they'll only tolerate 10 minutes, do 10 minutes. Just do what you can and realize that, you don't want to bite off more than you can chew, right? You just want to slowly. Okay. Negative symptoms. So you could have somebody who's just very unmotivated, very flat, not really socially connected. They're just having a very difficult time. And so we found this to be particularly challenging when we got to the narrative for some folks. In the narrative piece, you're talking about what happened, and folks will get real good at stating facts. It's about the thoughts that they have about themselves, about the world. It's about the feelings, those experiences evoked in them. So if you've got someone who's having a hard time sort of generating feelings, you want to make sure you're addressing those negative symptoms. So behavioral activation is a great way to do that. Getting them out there, helping them see that sometimes the negative symptoms are causing what we call this sort of paradox, where they think they won't have fun, but really if they get out there, they will have fun. They'll enjoy it just as much as they thought. So going out and doing those pleasurable things so they can develop a better sense in themselves of what's a pleasurable thought, what's a pleasurable memory versus what's an unpleasant thought or memory. And so we did some emotion induction with one of our clients. He was having a very difficult time connecting to those negative feelings. And so we watched YouTube videos of sad stuff or scary stuff or stuff that would make you angry, and tried to kind of say, like, are you feeling angry? Are you feeling sad? Are you feeling, like trying to sort of drive up those feelings, turn up the volume on them, if you will, so that then when we were doing the narrative, there was something to connect to, which that had sort of faded away for him. So that was pretty helpful. We also did a lot of writing, a lot of drawing. Like really, sometimes folks in drawing, you can connect to the feelings that it's harder to connect to in words. Recurrent crises. In TSCBT, these are called CALs, crisis of the week. So folks are just having a crisis. Every time they come in, it's a crisis, and you need to keep responding to the crisis, right? And so you will feel like, as the clinician, harried and tired and stressed out, right? Because these folks are draining you. And so again, it's really important to frame this as like, they don't have the supports they need. They don't have the coping skills they need. How do I sort of help them? So again, this is where DBT can be a very helpful frame, helping people to kind of focus in on what they're trying to accomplish in session. See if you can pull in other team members. Can case managers or other folks help you to enhance supports and community services to stabilize the system? Do you need to do parent training to help get the caregiver skills to sort of manage what's happening? And then again, if a lot of it is sort of intense emotional dysregulation or self-harm behaviors, this is where DBT skills can be really helpful. And we find that sometimes for families that are very chaotic and sort of constantly in crisis, it sometimes takes a little while for that to kind of calm down, for them to get to a place where they can manage doing the work. It takes a little bit longer. This is another big one we face, is family history of trauma. So oftentimes we have found that our clients with trauma have parents with trauma. moms with trauma, dads with trauma. And so sometimes what ends up happening there is the parent is avoidant. So they really reinforce avoidance in the young person. And so we've worked then sometimes that case, which might be a 1 hour a week case, becomes a 2 hour a week case because you're having to do the psychoed with the parent separately, teaching them coping skills, helping them work through that so they can be present in the treatment for their loved one. Like all of us, you're writing this note. I did psychoed with mom so she could be present with her kid and not pull them out of treatment. We created a mom's trauma group we actually do it in Spanish, just to do the psychoed together so they can have that sort of sense of community, hear the information together, support each other. It's been really helpful. But you've got to make sure that the support system is able to be present for the other person and tolerate what's happening. And so sometimes that becomes a collateral session and a client session. Okay. Rapid disclosure of trauma. Stop. Remembering, like you'll have folks who will come in that first session. You might even just hand them the cats and they're like, oh, I've had all of these. And then they will start to tell you about all of their traumas. Don't know. Wow, I can really see that you have a lot you want to share. How about we just do this form first? Let's start here. That will give me a place to start. And we'll figure out how to come back to this. And again, if they persist, you can say, I can see that there's a lot you want to share, right? We will get to that. Before you do that, I want to make sure we're both ready. I want to make sure you have the knowledge and skills. I know a little bit more about you, and we're ready to walk on this journey together. It oftentimes it's really like, I've told this so many times, I'm like now emotionally disconnected from it, and it doesn't matter. There's a lot of reasons people do it, but it's not okay. And we want to make sure we stop them before they go too far. Okay. This is a good one. The reality of the incident. Did this sexual abuse really happen for Roger? Grandma thought it did, but Roger says he doesn't remember it. Engage other collaterals, review records. If it turns out that the event was not real, but the person believes it was, right? Then you process the distress around the symptom, not the experience itself. What is it like to have these experiences when you feel like someone's touching you? Not you were abused as a child. If you, like in this case of Roger, just don't let go of it. Because he says no, that doesn't mean it didn't happen. You can just hang that back here in the back of your mind and see if other information comes up. I think the most important piece is, while that might have seemed like the most important part to Grandma, it's not the most important part to Roger. We are going to stay focused on what is the most important part to Roger. And that's what's going to guide our treatment. So don't get caught up in, did this abuse happen or not? Just stick it back there. We'll keep an eye on that, but let's keep going with all these things Roger has said. There's plenty there. Do not be afraid of exposure. Supervisors, this is your most important job. It's my important job, where I will hear in supervision about all the great psychoed and coping skills and family work and whatnot that's happening, and I will sit there and when are you doing exposure? We can be avoidant too, particularly if we're worried that we're going to make someone ill again. So just remember, move forward slowly, always check those SUDS ratings, shore up skills, make sure you practice. Sometimes for our folks, I like to cope ahead. Do some coping skills at the beginning of the session, then do your exposure, then do some coping skills at the end of the session, right? And make sure they have a plan for that night, because they might be really tired or stressed or emotional, right? You just want to make sure you buffer them in those things. Then we have to worry about us and secondary traumatic stress. You have to pay attention to it as a clinician. You have to pay attention to it as a supervisor. We have to engage in self-care, and we have to make sure our clinic is trauma informed. Because when we open this door, it is a lot to carry. And so we, as supervisors, as leaders of our programs, have to make sure our programs support our clinicians and staff in walking next to these clients and their families through these very, very difficult stories. Okay, culture, community, and language. I'm going to put in another plug for the formulation interview. Always circle back to this. Making sure you understand that individual and family and their understanding of their experiences. Another really important thing for us to keep in mind is that this sort of treatment, access to evidence-based treatment, is limited, really limited. I have trouble in Sacramento County finding good trauma treatment for adult clients. There's just not a lot of it. That's very frustrating for us. So just remembering that in rural areas, there's very limited access to treatment providers or training. And then like telehealth can help, but it only goes so far. And then there's some really exciting things that are happening that are coming out using non-professionals in this space, particularly in areas where there's a significant lack of access to mental health resources. So in our clinic, we collected some data on this. And I'm just going to give you a little bit of a whiff here. We've been doing this since 2015, and I have data on about 29 youth. You can see here pretty wide age range, diverse sample. More than 3/4 had first episode psychosis. About half had met criteria for PTSD. About 1/3 of them completed some of those TI-CBT components. So those are the little colored squares, right? Because we have our CSC circle that we go in no matter what, and then we integrate these little TI-CBT pieces. So only about 1/3 of them got into that next stage, while 12 of them had not. And about 7 of them were discharged to care. So for those people, this is stage 1 versus stage 2. This is all in Joanna's paper. So those folks who just were in CSC, had not really engaged in a lot of trauma treatment, that's the gray group here, versus the folks who had gotten into some of the trauma treatment. So what we see, here are the folks with the trauma treatment, here are the folks who didn't get there yet. And by 12 months, many of them were doing better. They get better, right? Positive symptoms went down for both groups by 12 months. Most of them were doing better. Depression, not quite as much, seeing some sort of mixed results here. These are small sample sizes. But some important pieces to note, that the people who were able to engage in the more directed trauma treatment tended to have less severe overall symptoms, less severe positive symptoms at baseline. They were a little bit more stable, whereas folks who were a little bit less stable, it was very hard to sort of get them engaged in trauma treatment. Oftentimes we saw those folks not be ready for trauma treatment until sometimes 12 months into care. We see that post-traumatic stress symptoms at baseline were much higher. These folks had much higher trauma symptoms at baseline for those people who we weren't able to immediately involve in care. But we do see in general trends over time for a decline in PTS symptoms over follow-up. So, some summaries here. Preliminary data show us that you can do this work and that folks don't get sicker. That was the biggest concern everybody had, is everybody going to get psychotic and go to the hospital? No, they won't. Those folks who will be more ready to engage more quickly in trauma treatment are going to be the folks who have lower symptoms, higher functioning at baseline. For those folks who are more ill when they come in, you need to get those psychosis symptoms stable. You need to work towards that stability. And then once you have it, then you can be able to integrate more of that trauma treatment. Treatment of trauma does not lead to an increase in clinical symptoms. Regardless of the amount of treatment received, the youth with early psychosis and comorbid symptoms showed a compatible reduction. And I can say a lot of those folks who were in the gray group, that sort of step 1 group, got psychoed on trauma too. And that itself, and they're going to get coping skills, they're going to get a lot of kind of core things, even if they don't make it to exposure. Okay, so we are now at the end of this presentation. Wow, I am so glad we added another 30 minutes. I hope that for those of you who have participated with us across both sessions, you're able to sort of see now how trauma is a public health issue that requires our clinical attention. And we really need to do a lot of research to understand its impact on poor outcomes. Trauma symptoms are very common in our population and overall contribute to a poorer course of illness and increased disability in the long term. It's also a risk factor in the development of psychosis. So, individuals with psychosis or at risk for psychosis should receive evidence-based assessment and treatment of their symptoms. Use of exposure treatments has good evidence, and preliminary evidence suggests it can be used safely in folks with psychosis.